All right, everybody, it's 8:50. Let's get back. Um, Hopefully your glass waters are full. So hopefully you guys started watching the videos for ACLS. I got them all posted. And I apologize. There's some little drop offs in there. I tried to get the best that I could with everything that I'm able to do over here technology wise. But again, your AHA stuff honestly is all video driven. With that, where we end up having the most fun and learning on that is basically just coming through and working them as we were before the whole COVID issue, going in and doing mega codes and discussing that. So, and that's what I hope to get back to, but we'll be able to get through the theory, some case studies, and all that other stuff and get everybody going. And then hopefully we'll come back in a couple weeks when they allow us and allow us to work what we need to on those lab nights. So please note, review all the posted videos with that from Life is Why all the way down to dealing with patients and DNRs and everything else like that. So, but the one thing that I want to do is regardless of whether you're talking about your chain of survival, your science of the resuscitation, everything else like that, please realize that the AHA does all the research in this stuff. So they are the driving force behind everything in cardiac care. So know your chain of survival from early access to high quality CPR to early access to defibrillation to early pre-hospital care, transportation, and then early interventions with that. So knowing this 5-point, because you will find questions on the registry as well as on your ACLS and PALS exams that relate directly back to this. So please know your chain of survival. I know it seems silly and everything else like that, but you really need to know it when we go along doing this stuff. So a couple discussion points. Regardless of what you do as a provider in the Commonwealth of Pennsylvania, please realize that when we take these certification classes, and your national registry, it is based in what the AHA considers its algorithms. Okay. So you guys have heard me say you want high quality CPR. I realize that in the field that there are machines now, mechanical CPR devices that allow us to do what we believe to be high quality CPR. But according to the AHA, they do not view those as frontline devices that you should be utilizing on every patient. Your first 10 minutes should be done with high quality CPR with every 2 minutes replacing your providers. Pennsylvania has the pit crew CPR and aspects like that. And I know that we've proven that putting a high quality, using a mechanical device, whether it's your Autopulse or whether it's a Lucas device, we're able to deliver high quality CPR with that. But when you read the documentations, when when they do talk about mechanical CPR, but they can't confirm or deny that you're going to use it, because the thing is, if they do recommend it, now there's a $14,000 to $15,000 piece of equipment that people can't afford. So it's a political move. It's that like that. But when you take your test, please realize that high quality CPR, rotating compressioners every 2 minutes is the right answer. Okay. And we're not going to debate it. It's what's in the AHA, and I want you guys to be successful. What you do on the street and what you utilize in that format is completely up to you and the policies and procedures of your operations. But I'm just letting you know what the AHA does. All right. So let's review. This should be burned into your brain as it is. Okay. In 2018, they updated this, but this is what you're going to be held responsible for, your static as well as your dynamic cardiac stations at the National Registry as well as on the National Registry Cognitive Exam, also known as the CAT. All right, so this is the universal circular algorithm for BLS, including ALS as well. This is what we all follow. We start CPR, we give them oxygen via BVM if we need to, or if you end up following along with high flow nasal cannula, apneic oxygenation, or anything else like that. But we check a rhythm. If you have VFib or pulseless VTAC, we shock them. Now, there's this discussion that goes on during this time frame at this point when you first start, where if it is a witnessed arrest, some people will say if it's a witnessed arrest, okay, then you start CPR right away and you put the AED or the monitor on and you defib as quickly as possible. There are other schools of thought that say if you show up and your patient was in cardiac arrest before you got there and it was an unwitnessed arrest, start 2 minutes of good high quality CPR prior to defibrillating if they are in VFib or VTAC. And again, that typically falls in hospital and stuff like that, just for the fact that it's sort of like starting an engine without gasoline. All right, you need to have gas, and if you're not perfusing those coronary arteries, what good is that AED and the VFib? So it's sort of like you have to make that clinical decision. But again, please realize that you have your partner that's doing high quality CPR. It's going to take you 30 to 90 seconds to get the monitor set up, turn it on, get the pads on, make sure you're on the right screen to make sure that you can see it, whether you use an AED, whether the AED function, or if you're hooking it up and getting making sure your leads are correct and everything else like that. If you're going to end up putting the leads on first and then putting the pads on, it'll take a little bit longer versus putting the pads on and turning it to the the pads function to where you can see directly from that, which is lead 2 anyway. That's going to add anywhere between 30 to 90 seconds depending on how well you apply to apply that. So it's kind of moot in that point with that. So just please realize that that's going to be I believe that's a clinical decision that you need to make at that point. All right. High quality CPR. Okay. Monitor that CPR quality. How are you going to monitor your CPR quality? Think about this, because again, you're going to need to transition from the BLS provider to the ALS provider, which is going to be responsible for everybody on that scene, including PD and fire and how they work around you. You're the crew chief. So how do you monitor CPR quality? Hockey yuck? Okay. You guys carry hockey pucks out there? Okay. Okay. All right. There's so many different types of devices out there. The hockey puck, the Zoll thing, stuff like that. Sean, end tidal CO2. What are you going to look for if you have end tidal CO2? But again, your patient at this point isn't intubated. But don't forget, you can, if you're using your nasal cannula, if you have your life pack or whatever, you can put, apneic oxygenation on and end up having expired CO2 coming out that way. So that's something to consider as well. If you don't have a puck, okay, or you don't have your end tidal CO2, what else can you utilize to help you figure out on your quality of that CPR? Does anybody here use the metronome function of the life pack or the Philips? I don't know if the Philips has one, but I know the 15 has. Or does any of you have the CPR monitor on your phone or a metronome that will tell you what is 100 to 120 times a minute? Or are you just going off what you think is good? And what do you do if you end up having someone there that is doing CPR for you that isn't doing it appropriately? either too fast. Sam B is going to yell at them. All right. Sam, are we going to do this in a positive manner? No. Okay. That's the Philly boy coming out in you, huh? All right. But again, that positive feedback and working as a team. And if you haven't watched the video yet for ACLS, be mindful of that because, again, you want at least hard and fast, at least 2 inches, complete recoil, 100 to 120 times a minute. Okay. Minimize interruptions. Remember, we're basically it's coming down to CPR. Continuous compressions is a good thing. Okay, is a good thing. Avoid your excessive ventilation. And each and every one of us is guilty of over-ventilating a patient. Okay, something we worked on in the beginning of the year, something that we continually work on when we ventilate our patients in simulation is over ventilating a patient. Again, oxygen, we're causing coronary spasms, all that stuff, as well as that intrathoracic pressure. All right. So all that stuff. So remember that. Okay. We've talked about, every 2 minutes. Okay. Honestly, every 2 minutes, move somebody in, move somebody out. Even if they are, even if it's before 2 minutes, get somebody else in there. Remember the ratios. If you don't have a advanced airway, which again for ACLS can be intubation, can also be an LMA. Okay. Or it could be a rescue device like a iGel combi tube, or a King LT. Remember 30 to 2. Okay, 30 to 2. If you have your waveform, like I said, we're looking for a quantitative end tidal CO2. You're looking at least 10 millimeters of mercury or greater. Okay, and watch for those spikes because, again, where's the CO2 coming from? Remember your physiology. Where is CO2 produced? This is a question for everybody. Where is CO2 produced? CMB, cellular level, where exactly is it made? Where's it actually at? Brandon, it's carried via the red blood cells, but that's not where it is made. It's carried. I mean, actually 96% of CO2 in our body is carried throughout the body in a form in the form of bicarbonate. Brandon Martin, byproduct of cellular respiration, but it is down where RJ said, at the mitochondrial level. Okay, it is the byproduct. It is the byproduct of ATP production. Okay, that's the only place it's made that we can measure it. That is then exhaled out. It is our waste product. So if we're not producing CO2, then our mitochondria is the cellular powerhouse, the body's powerhouse that produces that ATP, isn't working. That's why after 20 minutes, okay, if you don't get an end tidal CO2 greater than 10, that's why nowadays we're calling people in the field, okay, just for that fact, because if we don't get it started again, it's not going to start. We're not taking patients into the hospital that are dead. Okay. If we see that spike, that means that the ATP is being produced again. The mitochondria is going, the Krebs cycle is working, the citric acid cycle is all working. Okay. That's where it's formed. It's not formed in the lungs. It's exhaled through the lungs. Okay. It rides along on the red blood cell. And then it shifts with the O2 and the CO2 at the pulmonary capillary membranes. okay, but it's produced at the mitochondrial level, okay? So please realize that. We don't have, usually in the field, we're not doing any type of intra-arterial pressures. We don't have any Swan devices, so we're not going to worry about that one. When we defibrillate somebody, VFib, VTAC, pulseless VTAC. Please remember, if you're using a biphasic, we're going to go with the manufacturer's recommendation. And that initial dose, based on what you're going to do, is going to be anywhere between 120 to 200 joules, watt seconds, okay? And if you don't know, go with the maximum allowable. Okay, in your life packs, you're going with 360 Phillips, you're going with 200s, but know your devices. For your psychomotor, if you take it with us, you're going to be using a life pack 15, so you're going up to 360. All right, gather IV and IO access. Okay, whether you're doing a large bore IV, you're going to go large AC. Okay, use an 18 gauge or larger. If you're going IO, humeral head, proximal tibia with that. And again, that's going to be your decision where you're put. If you're the sole ALS provider, you're going to have to figure that out on you. That's where you're going to come, and you're going to have that systematic approach. You should become, by the time you graduate, you should become well enough. This should be like, walking and chewing gum at the same time. All right. Remember, once you get that IVIO access, remember, we then give epi. All right. Previously known as your 1 to 10,000 solutions, your 1 milligram or your 0.1 milligram per ml. Okay. With that, and then if you have VFib or pulseless VTAC, which is what we're talking about, you're going to go either with your amiodarone at 300 or your lidocaine. All right, pick one. Whatever you feel is you like to use with that, okay? It is really a personal choice. Whatever you feel is going to be beneficial to your patient, that's what you're going to use. But remember, if you end up getting pulses back, you get ROSC, and you use a certain antidysrhythmic, remember when you start your drip, use the same antidysrhythmic drug. If you use lidocaine for your initial dose, use the lidocaine for a drip. Same thing with amiodarone. All right, so your drug therapy is listed there, and we'll go into drugs on Wednesday. Your advanced airway, and again, if you're able to maintain a BLS airway, maintain your BLS airway. There's absolutely nothing wrong with that. All right, 10 breaths a minute, OPN piece, wonderful. If you can't control it, then go ahead with your blindly inserted airway device, and then if you think you can get it, then go ahead using video laryngoscopy as well as direct laryngoscopy. One of the things that I'm hoping to do once we get back into class is I have, I think, 3 styles of video laryngoscopes available for everybody to play with. That'll be, I think, the AirTrack. I think I'm getting a King 2, the Interbright, as well as the McGrath. But that's going to be dependent when we get back in class. They were supposed to be here this week, but I don't know where they're going to be. Okay. Once we go through this, please realize that there is going to be a secondary. Here you see the ROSC, return of our spontaneous circulation, and our post-cardiac arrest care. We're going to go into that, okay? But the one thing that we've talked about here is, and we've talked about it from, as soon as we started talking about this, about your reversible causes, your H's and your T's, your hypovolemia, your hypoxia, your hydrogen ions, your hyperkalemia, your hypothermia, tension pneumos, cardiac tamponades, your toxins, your thrombosis, pulmonary, as well as your coronary. Now, again, some of these for us may or may not be reversible. Like, we can't give TPA in the field. So, maybe if you get recurrent VFib, VTAC, and you think that they had an MI, put them on the Lucas. Those individuals may get transported, because you transport them in now, we can take them up to cath lab in the receiving facility. If you do have a PCI available cath lab, they can actually float in catheters with that on them. All right, so think about that. All right. Once you, the hypoxia, the toxins, all that other stuff, cardiac tamponade, we can't do pericardial centesis. So that's something, but again, your history is going to be able to give you that. And you call command and say, hey, doc, I think I got this. Because one of the things with the cardiac tamponade is going to be your PEA. And that's something here that all of this stuff here doesn't really touch on. So I'm going to spend a little bit of time there when we look at those H's and T's, because our H's and T's are going to be the causes, rather, are going to be things that we look at specifically when we begin discussing PEA. Please remember, PEA is pulseless electrical activity. And yes, VFib and VTAC are PEA, but they're a specific type of PEA. Okay, we're looking at PEA in that rapid tachycardia. We're looking at that underlying sinus rhythm, all right, and everything that goes along with it, all right. So frequently listed causes of PEAs when we look at that H's and T's, okay, we talked about hypovolemia. How do we fix hypovolemia? How do we fix hypovolemia in a non-traumatic patient? Because again, when we talk about ACLS, we talk about our medical patients. And when you start dealing with traumatic causes of cardiac arrest, it's an entirely different thought process. And that was something that I wanted, and that Dr. Brayburn and all those guys were teaching you about, where we look at that as complete. It's a different thought process. Because in your traumatic cardiac arrest, it's not secondary to a electrical issue, it's secondary to a physical issue. So giving drugs and giving electricity may not be the best thing to do. Just like in hypovolemic cases with sanguinating patients, okay? Those sanguinating patients, giving them all of that isotonic crystalloid may not be a very good thing. Because especially if they're sanguinating out, because again, we're diluting, that hypovolemic lethal triad. We're inducing hypothermia, where we are diluting clotting factor, okay, as well as isotonic crystalloids do not carry oxygen. We're not replacing. That's where whole blood comes in, and that's where the whole trauma issues of dealing with an ATLS issue is going on. All right, so that's something to think about. All right, but again, hypovolemia, how much fluid are we going to give somebody in a cardiac arrest? What are we going to hang? What do you think? And there's one, lactated ringers. What's the other most common isotonic crystalloid that we're carrying pre-hospitally? Normal saline. Very good. So those are the two. But again, please remember that, again, when we talk about hypovolemia, when we start dealing with these medical conditions, we're talking about that. We're talking about that 500 cc bolus up to a liter maybe, because again, remember, cardiac output equals heart rate times stroke volume. We need to make sure that there's enough volume in there. Maybe somebody's dehydrated or something like that. We need to make sure that there's enough. It's going to be a little diluted, but 500 is not going to kill somebody. It's less than 10% of our total amount of our circulating volume, to make sure that we have enough fluid that's going through the pump, okay, to going with that. So hypovolemia, when we look at it, and I don't care if it's ringers or saline, okay, they on your tests are going to call it an isotonic solution, crystalloid solution. Hypoxia, guess what? We're going to fix that, aren't we? Because we're going to ventilate our patient appropriately at 10 times a minute. Unless, of course, with trauma, we'll talk a little bit later in ITLS, where we're talking about trauma and, where we end up having somebody, cord injury, we may want to hyperventilate somebody at, like, say 16 to 18. Okay. But for our hypoxia, if we ventilate somebody, 10 times a minute, 12 times a minute, normal volume, remember 500 ml, okay, remember, that's going to take care of a lot of our problems. That also is going to fix our hydrogen ion issues, our acidosis. Okay, unless you have a pre-existing case, TCA overdose, salicylate overdose, your dialysis patients, those pre-existing issues, individuals that go into cardiac arrest, ventilating them for 1 or 2 minutes at a normal rate is going to be enough to fix that. Okay, so walking in on a cardiac arrest going, I'm going to, we ventilated, I'm going to dump in 2 amps of bicarbs or 100 MEQs of bicarb really doesn't work very good. If you've listened to those podcasts for foam crit, and they talk about the critical care, in those cardiac arrest situations, it's easier and it's more beneficial to your patient to treat that acidosis with ventilatory support versus start dumping in all those drugs, unless we have definitive lab results to where we can actually start titrating that. And one of the things that you'll realize as we get into the medications with this is ACLS calls for drips of epi, and they'll talk about dumping in some bicarb via an infusion. Please remember, we're not allowed to do that. That's why we give push dose epi, because we don't have what's those things called? Pumps. We don't have pumps. Thank you, RJ. We don't have pumps, so we have to use something else. Now, if you end up working on a critical care truck later on in life and you're allowed to do that, then that's a different treatment that you're allowed to do. But as we walk out, we have to do that push dose epi. But when you read when you read AHA and when you read the National Registry, please realize that they're allowed in the curriculum to utilize pumps. So with that, we also have the hyperkalemia. We have the hypokalemia. Please realize with the hyperkalemia, when we start dealing with hyperkalemia, we end up giving the calcium chloride, okay, which calcium chloride has 3 times the bioavailability versus calcium gluconate. So just be mindful of that. We have hypokalemia. Now, there's really not much that we can do with hypokalemia in the field because we don't carry potassium. Most of the time, critical care truck, maybe, but that has to be on a pump. And most individuals are not throwing in a whole bunch of potassium with that. We do have to worry about hypothermia. Getting a good temp is very important. Whether or not that be axillary, orally, rectally is the preferred method. Please remember your LifePath 15 can take a rectal or oral tracheal temperature, but it takes at least 5 minutes to zero out your 15 or your monitor when it comes to the temperature. Now, when we start talking about hypoglycemia, please remember with hypoglycemia, it doesn't affect the cardiac muscle. Okay, it doesn't. Now, once you get ROSC and you need and you're trying to figure out why your patient's not waking up, if you want to go ahead and drop a glucose stick or get a reading on it, that's fine and dandy. But we're not, years ago, and the reason why they put this here is years ago, it used to be in the ACLS that we would give the patient a D50 in cardiac arrest, just to roll it out. But research has shown that it doesn't affect the cardiac muscle. That's the potassium and sodium. So it's not one of those things. But later on for ROSC, let's draw some. Now, that does differ when it comes to kids. We do need to get a quick glucose on those kids as quickly as possible, off than not. Toxins, when we look at whether it's a respiratory toxin, whether it's a integumentary toxin or anything like that, we need to worry about toxins. Okay, one, not only from the patient's point of view, but also from your point of view. Please remember, if you go running into a house that patients are now unconscious and everybody was complaining of nausea, vomiting, and headaches before you went in there, do me a favor, get out, there's something going on. You want to be careful as well, because you don't want that patient giving you whatever they were exposed to. So be mindful. But again, when we start looking at toxins, the vaping issue, were they taking K2? Were they taking some type of pharmacological, betterment for themselves, better living through pharmaceuticals? So a good assessment will help with that. Please also remember, when we look at toxins, a lot of people will throw in there, opioids. Please remember, opioids block neurotransmitters secondary to the respiratory centers, not the cardiac centers. Even if a patient is in cardiac arrest secondary to a opioid overdose, giving Narcan won't fix it. CPR and ventilations will. Down the road, maybe, but right there, Narcan is not going to save it. It is not a cardiac drug. You ventilate your patient, you work it as a cardiac arrest. And if there's the potential, if you get ROSC, then potential. But again, we're only giving the Narcan for the respiratory rate. Tamponades, and again, cardiac, when we look at that, that can only be fixed in the case of a pericardial synthesis. When we look at that in today's technology, ruling that out is a lot easier, especially if you have access to POCUS, point of care ultrasound. That's something that's on its way up, something that we can figure that out utilizing that as well, if you know how to utilize it. Okay, but again, high quality CPR with that. Tension pneumothorax, again, that's something that we can diagnose in the field. If you intubate somebody, okay, unless you have a right main stem bronchus in a normal patient, you should have lung sounds on both sides. If you don't, you verify your location, you're in both, but you're losing something on the left or the right, you're in the right area, you're on the superior aspect of the carina, then at that point, you're going to needle a chest, okay, to rule that out. And honestly, if you're working a PEA and your last ditch effort, you don't know, most docs will say, hey, double needle the chest. We don't know. Okay. We've already talked about thrombosis, coronary or pulmonary. With that, we really can't fix that. But if we get them to the hospital, if we think there's a chance of that survival, especially now with newer research and utilizing there's Reboa technology, there's all of the stuff going on, like we talked about earlier with John Davids, and using all the newer technology, that may be a possibility. And depending on where you end up working, that may be a treatment down the road for somebody that's in PEA. They threw a PE, they threw the big one, high quality CPR, get them to the hospital, and then they could end up taking them up to CATS to into EP lab and into the cath lab and trying to clear all that stuff. And then trauma, and again, it's in parentheses there, because again, it's the PEA in trauma is there for a secondary reason. Usually that's because of a physical issue. Homeostasis has been broken, secondary because you're bleeding out, you've torn something. The amount of epi and the amount of epi and the amount of defibrillation you're going to do in those patients isn't really going to do you very, very good. Those patients need surgical intervention, and quickly, and they need whole blood, packed red cells and everything like that. So remember your PEA. All right. So PEA actually is, if you look at the newest numbers, which I did researching this, account for approximately 1/3 of all cardiac arrest, and are even more troublesome when the survival rate is significantly worse with patients with shockable rhythms. And Brandon and I went back. We're going back and forth the other night about some of the interpretations on the EKGs when we look at what the ACLS calls VFib, VTAC. And one of the things that Brandon and I had chatted about a little bit was the need for the human condition to do something. What is this? I don't know, but let's shock it, right? With PEA, it's very difficult for providers, especially at our level, to go, well, high quality CPR is going to be it. Research is showing that's about it. High quality CPR, but what they're trying to do now with the newer research is to classify PEA. classifying PEA if it's narrow versus a wide complex, and some differential diagnoses that you can see by looking at the research and looking at your EKG morphology. So if you determine the PEA is narrow or your QRS is less than 0.12, okay, it's usually due to a mechanical problems caused by right ventricular inflow or an outflow. So guess what that is? That's a PE. Okay, on that right side, because the ventricular inflow coming in, whether they've got something going on before that or an outflow, meaning it can't get through the lungs, with that secondary to a PE. So be mindful of that. So if you look at narrow complex, it can be due to mechanical problems on that right side. Whereas you typically look at a wide complex, okay, greater than 0.12, it's probably due to a metabolic issue, ischemia, or left ventricular failure, hypertrophy, something like that. So that can give you a little bit of idea on how you want to treat that rather than just say, oh, it's PEA. When you call command and say, hey, I've got a narrow complex PEA, or hey, I've got a wide complex PEA, give them that issue. So this picture here is just this picture here is just a visual representation of what I just said. When we look at that QRS narrow, it's a mechanical problem. We got a tamponade issue. We got a tension pneumo. We got mechanical hyperinflation or a PE, as well as we can also have a myocardial rupture or an acute MI, okay? As well as left ventricular hyperdynamic pseudo PEA, and that's beyond our scope at this point. QRS, the wide one, we're looking at that metabolic issue, severe hyperkalemia, sodium channel blocker toxicity, okay, your agonal rhythms where you get that wide, Brandon, remember we were talking about this, that widened agonal with periods of asystole. This is where that, again, that PEA, again, depending on how you want to call it, and you as a clinician are going to have to make that choice. And again, the more specific you can be to command, the more they're going to let you do what you think you need to do. All right. It's also going to lead us to acute MI pump failure or the true PEA and stuff, again, that's beyond our scope at this point. But this is just a evaluation of PEA versus wide versus narrow. All right. So how do we treat this? If we end up with a narrow QRS, that mechanical right volume, we want to give wide open fluids. Okay. Wide open fluids. And again, when I say wide open, please realize, we don't want to, make sure they're not bleeding out somewhere. And again, one of those common bleed outs, especially for our elderly population, is going to be a GI bleed or a rectal bleed. So, do a complete assessment. Hey, has the patient had any coffee ground emesis? Patient had any black tarry stool or anything else like that? Ask that question. And if you have to, send somebody to the toilet to look what's going on if they had flushed or something like that. That is a assessment tool. While it sounds disgusting, it is an assessment tool that you should pick up on. Okay. And if you consider cardiac tamponade, if you take them to the hospital, they're going to end up having to do a pericardial centesis. Or if you're lucky enough to work in a system where your doc comes out with you once in a while, guess what? 9 times out of 10, they're going to carry this stuff and they'll be willing to do it and talk about best patient scenarios. Tension pneumo, guess what? Decompress them. Okay, and that's where that comes in at that last ditch effort. If you hyperinflate, put them on ventilation. If you think you're starting to, you've got an overzealous EMT or somebody that's bagging somebody at 40 times a minute, tell them to slow down. Okay, watch that 10 to 12 times a minute. Okay, that can impede your treatment down the road. And then if you end up having a PE or a coronary embolism or something like that, they're going to end up, whatever, taking them in. Most of those patients, unfortunately, by the time we're dispatched, we get there, you're at 20 to 30 minutes already, your overall treatment. So that may end up not being anything at that point. But again, if we go wide with the left ventricular, you want to give your pharmacologic issues, hyperkalemia, your calcium chloride, like I talked about, if you think that's an issue, or if you've got a sodium channel blocker toxicity, or if you end up having individuals that are dialysis patients, please realize that that's something that you may want to consider giving bicarb. 50 1 MEQ per kilo, but please realize your patients, and they only come in 50 MEQs, your big ones. So be mindful of that. But this is all things that you should be thinking ahead about and working on down the road. Now, this should be something that you are very familiar with. All right, this is your typical cardiac arrest algorithm outside of the universal one, where we start looking at when to give EPIs, when to give our antidysrhythmics, when to do what to do. So you guys should have a good breakdown on this already, because I've given it to you and you've been working out in the field. Okay, so again, this is something that helps you think about what we want to do. If you have vfib, vtac, okay, CPR within 2 minutes, 2-minute intervals, switching providers, or if you're, again, AHA, you're going to do high quality CPR with personnel, at least for the first 10 minutes. But again, in reality, vfib, vtac, get them on CPR, unless there's cases of obvious death. Decapitation is a really big one. I don't know if you guys have ever shown up on scene and the squad, the first responders are there and they have a decapitated patient, the head's barely hanging on, and they're doing CPR. Give them an A for effort, but at some point you go, hey, why don't we back off a little bit there? But again, and again, if individuals are putrefied, or if they're, rigored or something like that, as a clinician, you should be able to pick up on that as quickly as possible. VFib, VTAC, remember, we're going to shock in 2-minute intervals as well. Anytime we do a pulse check or something like that, is that rhythm shockable? Guess what? In mega codes, 9 times out of 10, most of the time, they're going to flip-flop from a PEA to a VFib to a VTAC to a normal rhythm. Check pulses. Okay, so that's something, and watch your end tidal CO2, because that's probably going to be your first line of observable change where, oh, wait a minute, it just went from 10 to 72. Guess what? We got something. Somebody check for a pulse. And please remember, even though somebody, you think may have a pulse, but it's very, very weak, it is okay to continue CPR. Now, one of the things that this doesn't really talk about, and this is something that's kind of off the reservation sometime, but it's it's becoming more and more prevalent, especially with the use of our mechanical CPR devices, is CPR-induced consciousness. If you've never seen this before, it's really freaky, where you're doing CPR and your patient is awake. They're either yelling at you, moaning, or their eyes are following you. But as soon as you stop that CPR, they're in cardiac arrest again. So please be mindful like that. There's a lot of ancillary discussion going on. Do we sedate people during this? And there's a lot of different discussion going on. But please be mindful with that. Okay, but again, in these initial, honestly, 8 minutes, 10 minutes of a cardiac arrest, we're high quality CPR, we're giving them O2, we're shocking them as needed, we're starting IVs, IOs, and we're giving epinephrine, AMI, and or lidocaine. Okay, that's the drugs that you need to become familiar with in your initial 10 minutes of cardiac arrest, and that's basically what this algorithm is showing us. When we start getting into individuals that are not in cardiac arrest, okay, we're looking at patients that are bradycardic. And again, we have bradycardia or we have tachycardia. But again, when we start seeing individuals with this bradycardia with a pulse, we have to make that clinical decision. Are they hemodynamically unstable, stable, or sick versus not sick? I don't care what you in your brain, but think about it that way. Okay, typically according to AHA, I know bradycardia is usually defined under the number 60, but again, typically we're they may say 50 according to AHA, but again, it's one of those things. What do you see? Hemodynamically unstable. If they look like If they look very, very bad, regardless of the heart rate, you got to figure out what's going on. The patient will dictate how you treat them, really. Airway, breathing, circulation. Okay, hypoxia is usually less than 94% on a pulse ox. Hook them up to an end-tidal CO2, see what they're doing. Okay, even if their pulse ox is high and they've got nail bed cyanosis, if they've got lip cyanosis, altered mental status, please remember that's one of the first things that goes wrong with somebody is their airway. Okay, they may need that oxygen, or they're hypercarbic. Remember, hypooxygenation also leads to hypercapnia. So watch those words on exams when you see, hypooxygenation, hyperoxygenation versus hypo or hypercapnia. Okay, know what those mean. Okay, in these patients, put them on the monitor, maybe run a 12 lead, get their pressure. We've talked about oximetry already, and put a line in them. Okay, because at this point, here comes this decision tree. Is that bradycardia causing significant hypotension, altered mental status? Okay, are they having signs of shock? And shock is defined as, and everybody better sound off, shock is defined as, what is it? Start typing now, RJ.
Inadequate perfusion.
There you go. Which can be, manifested in multiple manners, altered mental status, all that other stuff. So is their bradycardia causing their signs and symptoms? Are they having chest discomfort? Is it related to ischemia? Okay, are they in heart failure? Okay, listening to lung sounds. Do they have peripheral edema? All that other stuff. Now, this is where you end up having that decision tree. If they're not that bad and they're not feeling well, but they don't hit any of those things, okay, monitor and observe. Maybe give them a little bit of fluid. Maybe they're a little dehydrated. They're feeling better. 9 times out of 10, that's what the problem is. But if we have another issue, you've run that 12 lead, they're bradycardic, what's going on? Figure out what's going on. If they start getting good, wonderful. If they start getting bad or worse or maintain status quo, you may want to consider a couple different things. Okay, one is atropine. Okay, greater than 0.5 milligrams up to 1. Okay. You can start, if they're really, really sick, then you go to TCP, transcutaneous pacing, okay, as we've practiced in lab, or you can go with, all right, dopamine or epi infusions. Now, those, as you can see here, looking at the doses and details off the right here, okay, they're talking about dopamine and IV infusions. Now, dopamine we get away because we drip it, and that's why it's important to know the drip rate and how much you're going to figure out. And again, AHA looks at 2 to 20 mics per kilo, and I know our protocols say start at 5, okay, but we're looking at 2 to 20 for AHA. Epinephrine, we don't do drips, okay, we do push dose epinephrine, which is typically 10 to 20 mics per ml in that 1 to 100,000 or in that dosage as we mix down from the epis. Okay, so be able to pull that out. Now, most of the time prior to giving the dopamine or the epi, please remember we want to start fluids on these patients. Okay, again, they're following the AHA probably 2 to 20. Yeah. So please realize that before this is you want to make sure that they're fluid challenged, okay, that they've got enough fluid in the pump before you start dumping vasopressors and all that other stuff into them, okay? Make sure their lungs are clear, everything else like that. But again, we've seen this before. Now, on the opposite side is their tachycardia with a pulse. And again, the whole thing comes down, typically this is, heart rate typically is greater than or equal to 150 to 160 before we start getting into that realm. I've always been taught 160, depending on the situation, look at that 160. I talk to other people, they're, hard number at 150. But again, I've always looked at it as, okay, what were they doing? Were you just sitting here watching Jeopardy, or were you running a marathon? So again, it's that clinical decision that you have to do. Airway, breathing, circulation, put them on the monitor, get a good 12 lead, because maybe the tachycardia is showing up in lead 2 and it's really quick, it's really narrow, and you're like, oh, is that an SVT or is that a VTAC? But you look and it's not across the whole idea. So run a quick 12 lead. Always get that going. And then, is this arrhythmia going to cause hypotension? Is your patient sick versus not sick? Okay. They have an altered mental status, signs of shock, chest discomfort, or acute heart failure. Didn't we just see that over here? So there's a lot of repetition here, And if they're sick, okay, if they're really, really sick and you have to consider synchronized cardioversion, they have here consider sedation. If they're really, really, really that sick, sedation kind of goes out the door, because most of the time, now ketamine's a little bit different if you're going to use ketamine, but most of the time the sedation that we end up takes time to draw up, takes that, as well as can cause hypotension. You're trying to fix that, right? So that's a consideration. Narrow complex, you might want to consider adenosine, 6, 12, and 12. All right. Also, if you end up getting that widened QRS or something like that in this, as you're trying to narrow it down to figure out where this is coming from, maybe a vagal, you're not throwing ice water on the patient's face. You're not doing carotid massages or anything. Just have the patient bear down. Now, what if the patient has altered mental status and cannot bear down? Guess what? Then you might just want to skip and go straight to cardioversion. That's going to be a decision that you have to make along with medical direction. Okay. And again, when we go down, looking at adenosine and some other stuff, if you carry a calcium channel blocker or you're a beta blocker on your truck or something like that, those are considerations down the road. You get your cardizem and all that other stuff as we go down. But again, it's one of those things that you're going to have to make a decision. Now, one of the drugs that you should have a working knowledge of if you're carrying it is the procaminide. In those wide QRSs. When we start looking at that, procaminide is 20 to 50 milligrams per minute until the arrhythmia is suppressed. Hypotension ensues, or the QRS duration increases by greater than 50% of the original. So you're going to have run a strip, okay? Or you've given a maximum loading dose of 17 milligrams per kilogram, okay? This is a wonderful question that you will see on the National Registry if you are so chosen. Okay, it's one of those things, and usually they throw the procaminide question out there. Typically it's a third line for us. We do in those widened ones, we look for amiodarone for the narrow one, adenosine for the narrow ones. We get to the wider ones, we're looking for lido, amiodarone, and then procaminide. And one of the things you may see down the road in the next 2021 edition, we may see a resurgence of beryllium coming in. Not right now, but I've seen research coming in where we may see it again. But again, procaminide is one of the old drugs. It's usually third or fourth down the road, and they love to throw those questions in there. What is your stopping point for procaminide? All right. Honestly, everybody, these should be memorized when we go down. When we look at immediate, let's say you've done everything perfectly, your patient, you get ROSC. What do we need to do? Okay, you get pulses. Okay, in Pennsylvania, they comment in the one medical play on the X, stay on the X for at least 10, 15, 20 minutes to stabilize everything. Okay. So we get ROSC. One of the first things we want to do is maintain that oxygen sat greater than 94%, whether that's BVM, OP, NP, intubation, and blindly inserted airway device, whatever. You want to keep that around 35 to 40. Now, please remember, if you've been in VTAC, VFib for a while and the patient may have been down, you may have a higher end tidal number. you want to get that, ventilate appropriately without excessively ventilating and get them down about 35 to 45. Okay. Treat your hypotension. Typically, we're going to give them your fluid, and again, a liter or so. You want to keep your pressure greater than 90. That equates to a MAP of about 60, which will allow for cerebral perfusion. As we continue going down, now please realize, even though we do have this, in this algorithmic form, please realize that this, if you have another medic, you can do things simultaneously. Okay, it's just on the test that we want, they want to see you do one thing at a time. All right. Once you get all this done at the same time, hopefully you've got your 12 lead hooked up to where you can do serial EKGs, and just keep hitting them. That gives a wonderful story to the physicians when you got in. Hey, doc, here's what we saw. We got ROSC. Here's what we saw initially. Here's what we saw 10 minutes later, 20 minutes later, right outside the door. We can see this progression. And they can tell you different things, do they follow commands, everything else like that. Usually for us, with number 7 here, where it says initiate TTM, targeted temperature management. If you do get ROSC, you open them up to ambient temperatures. We're not worrying about flowing cold saline into them. We're not worried about putting, cold saline in the axillaries or on the carotid. Okay. It's too difficult for us to do. Okay. And it showed no results in the initial, research that came along with this. But one thing you do want to do is cool them down a little bit, open them up, turn the AC on. Okay. Get them a little bit cooler to that while maintaining, please realize, while maintaining the privacy of your patient. But again, try to get that targeted management. It's not too low. It's like 95. I forget the actual number right in front. Yeah, I don't have it right in front of me, but we want to cool them down, and again, notice up here that will follow with your fluid challenge, they're calling 1 to 2 liters. You get something that's, room temperature. Remember, those IV bags sitting in the back of your truck or sitting in your trauma bag will assume ambient temperature, unless it's direct sunlight, usually right around 72 to 78 degrees. So that's approximately 20 odd degrees lower than the core temperature if your patient is normothermic. 98.6, you're giving somebody, let's even say 78 degrees, it's 20 degrees below. The heat is going to move from the body to the fluid, and it's going to cool them down a little bit. Okay, so we will start, since it's 10 to 10 on Wednesday. We will start with an ACLS case study, and then we will continue in and go through another NR-EMT cardiovascular one, and then we will go into more in depth when we start looking at the drugs and everything that we move along, and we'll go back and refresh everything as we go along. Okay, so I hope everybody has a good night. Unless anybody has any questions, comments, or concerns at this point, that's it for me. I'll see and talk to everybody on Wednesday.